Welcome everyone. This is the Rotary E-Club of Silicon Valley, and every week we try to bring you programs that will inspire you to see new possibilities in the world. We have a special interest in the topics of innovation, entrepreneurship, and education. As Rotarians, our big focus is service above self. That's our motto. Rotarians are a group of people around the world, 1.2 million of us, as a matter of fact, in 33 or 34,000 clubs, all of whom are there to be able to make good things happen in and beyond their communities. So for our club, the Rotary E-Club of Silicon Valley, one of the things that we like to think of as part of our service is to find these wonderfully interesting speakers who can tell us about all sorts of things that allow each of us to see something new within our own possibilities for how we help our communities. Now, today's speaker, Michael Gray, a proud University of Louisville graduate, is part of the Treatment Advocacy Center. You may remember Elizabeth Hank presenting to us quite recently, and he is going to allow us to look at things from another angle again. While this has a lot to do with the situation here in the United States, we do ask all of you internationally who might be watching this recording later to share in the discussion section how things might be happening in your country. So Michael, who is with the Treatment Advocacy Center, also spent quite a few years with NAMI, the National Association for Mental Illness, and is one who is constantly working to improve the lives of those who suffer from a variety of mental illnesses, especially with regard to how state governments treat different kinds of rules. And he will be telling us very specifically about a rather counterproductive piece of the Medicare law. So with that, Michael, it is so good to have you, and I hand it over to you for the presentation.
Rushton, it's so good to be here with you. And as Rushton explained to you all, I'm with the Treatment Advocacy Center. My name is Michael Gray. I'm Legislative and Policy Counsel there. And like most DC job titles, that doesn't tell you hardly anything about what I do. And that is advocacy around state laws related to severe mental illness and the treatments thereof. So moving right along. You remember recently my colleague Elizabeth Hank spoke to you all about the bed shortage, the lack of inpatient treatment beds for people with severe mental illness in the United States. I'm going to dig a little bit deeper into that topic today. And quick overview, even quicker than Elizabeth was, of the Treatment Advocacy Center and what we do there. We are a policy group. We are an organization of people who works to reform laws to increase access to treatment for severe mental illness, founded by and still a board member, Dr. E. Fuller Torrey, one of the world's foremost experts on schizophrenia, bipolar disorder, and other severe mental illnesses. And we are unique among nationwide mental health and mental illness advocacy organizations in that we do not accept funding from certain types of companies. I'm not saying those companies are inherently good or bad. It's more about avoiding bias and keeping our objectivity when it comes to our advocacy work. So some quick facts here, and you'll learn very quickly that I'm not heavy on statistics and numbers when I talk to people and talk to groups, but these are some important ones. There are over 8 million people who suffer from SMI or serious or severe mental illness. Those people are not getting the treatment they need. They end up way too often, most of the time actually, when they need treatment for psychosis in emergency departments and emergency rooms. They are likely to be the victims of crimes, in addition to the things you read about in the news of these people perpetrate crimes because of their mental illness. And when these illnesses are not treated, what happens is people end up in jail and prison, even though it's the illness and not the person who committed the crime. They end up homeless, and all of the detriments and downfalls of homelessness in this country. And there are many other negative outcomes related to lack of treatment. And when Elizabeth spoke to you all recently, she talked about the shortage of beds overall. I'm going to talk to you about one major component, one major reason of why there are so few inpatient psychiatric beds available in the United States and California, all states, including California, for people who badly, badly need them, when they need them, to get treatment for psychotic illnesses, to make them, I won't say well, but to get them stable so they can start on that road to getting a full continuum of mental health care. So, a little background on Medicaid and Medicare. We're talking about a Medicaid waiver and a Medicaid rule today, but quick background. Medicaid, Medicare came about in the mid-1960s during the Civil Rights Movement. There were a lot of social programs passed by the Lyndon Johnson administration and Congress during that time. This was one of those programs. Medicare provided health care for the elderly and other populations. Medicaid, low-income individuals was the original intention of Medicaid legislation. If you have more questions about the origins of these things, please hold them for the Q&A because it's one of my favorite topics. Moving on, what does Medicaid do today? Health insurance for 1 out of 5 Americans is a secondary insurance for 10 million people on Medicare. And you see the other aspects of it there when it comes to long-term financing of long-term care and who's going to pay for long-term care. Sometimes that's Medicare, sometimes that's Medicaid. It depends on the patient. And many of the people that we're concerned with at the Treatment Advocacy Center, they need a little bit of both. They need those 2 payer sources and other sources as well, because our system is so disjointed when it comes to both providing healthcare and paying for healthcare services. Let's talk a little bit about what Medicaid can do and what it is. It's a program that is administered by the federal government and the state governments. I always like to joke, although it's true, I like to joke that Congress had this brilliant idea in the 1960s that if we allow the states and the federal government to jointly administer something, that it will be an efficient way to pay for healthcare. Of course, it's not efficient. It's inefficient. The state governments and the federal government disagree about many things on a daily basis. This is one of those things. There are effectively 56 different programs, 50 states, the territories, and DC. And there are these rules, these federal rules and laws that say this is how you, states, shall administer Medicaid, but the states can ask for waivers. A waiver is exactly what it sounds like. It is a state asking the federal government to waive one of the rules, one of the requirements of Medicaid. One of those rules has to do with IMDs, and that's what I'm here to talk about today, Institutions for Mental Disease. That is a facility that is in the business, whether it be for-profit, private, state, nonprofit facility, they are in the business of providing inpatient mental health care or psychiatric services. There's a rule, and you can see it there on the slide, but there's a rule defining what that is. But in reality, it's one of many situations in which the federal government, in this case, the Federal Centers for Medicare and Medicaid Services, says, we're going to determine on a case-by-case basis. This hospital facility is an IMD. Maybe this one over here, they'll say isn't. But more often than not, when a facility has more than 16 inpatient psychiatric beds, that is considered an institution for mental disease by the federal government, and that means the federal government will not provide Medicaid funds for services provided in that institution. That is the IMD exclusion. So for the better part of 60 years, we had this rule, the IMD exclusion. The federal government says we will not pay for treatment provided to individuals in such institutions, these IMDs. Then along comes the culmination of a lot of behind the scenes lobbying of the multiple administrations, the executive branch of federal government, as well as Congress and some state governments by organizations like ours and others, culminating in the federal government saying, okay, we're going to allow you states to apply for a new type of waiver. Once again, a waiver is just a request to the federal government that we would like to waive this rule, in this case, that IMD exclusion rule. This waiver has 2 goals. One, to take advantage of the strategies under existing authorities, meaning many of the services already provided by Medicaid and or Medicare for people with severe mental illness, to make sure those are being used and that they're being utilized as part of a full continuum of care. Number 2, actually waive the rule in a specific state when the state applies for it to do so. This comes under Section 1115. Now, I don't like to use a lot of numbers and so forth when I talk to groups, but I'll tell you, 1115, or in our jargon, 1115, is a very important one when it comes to Medicaid policy. It is a type of waiver that the feds call a demonstration waiver. Quite literally, asking permission to not just waive a rule, but to waive a rule as part of a demonstration to show to the federal government, we, the state, has a way to make this part of the system work better in our state for our Medicaid eligible folks in our state. This particular one came about, as the previous slide mentioned, in November of 2018. And that is one of those things where in public policy, sometimes time moves quickly, sometimes it moves slowly. This is very much a hurry up and wait kind of thing, because so many advocates like me and my colleagues and a lot of families and other lobbyists I've worked with over the years were thrilled to see this opportunity for this waiver come down. But now we have to wait. It's a hurry up and wait. Okay, now the opportunity's here. Now states must apply for it. State governments, state Medicaid departments, I believe it's Medi-Cal in California, they would have to apply for it in order to get it. You don't get it automatically. You must ask the federal government for it. There's some work involved there. Of course, the outcomes here would be good. I don't know anyone, any smart policy wonk or any advocate on the ground or any concerned person with a relative with severe mental illness who would disagree that it would be good to waive this this Medicaid rule and obtain this waiver. However, there's some work involved, and all the things listed on here, some highlights about the using improving existing services, about tying in this waiver to other items to make sure that there's more Medicaid funding available for inpatient psychiatric beds in psychiatric hospitals. It requires some heavy lifting by those states. And so far, we've seen, I believe we're up to 7 states, and there they are, that have applied for this waiver, and 4 of them have received it. I should say 6 states in DC. In some ways, DC is like a state, in some ways it's not. But when it comes to Medicaid, it functions like a state. There is a DC Department of Medicaid, and just like my home, the Commonwealth of Kentucky, or your homes in the state of California, and for many of you watching around the country, your state has or territory has a Medicaid department. So does DC. And so I know we're live, but my dog just snored at my feet, and I apologize for that. He's very large and he's very loud, and he's been sleeping, which is better than barking, but he just let out a big snore. So anyway, you may have caught that, but no. Yeah, so you see DC, the 3 other states that have obtained this, and 3 that are pending, and we expect those to be approved. So what can you all do? What can you do to get involved? There's lots of guidance that I can provide and that other advocates that I can connect you with can provide related to your state and related to the big picture federal level stuff. But the bottom line here is that people are not being treated for severe mental illness in our country because there are not enough beds to go around. Will this specific IMD exclusion waiver, this type of 1115 demonstration waiver for Medicaid, fix that problem on its own? No. However, it is one very, very important piece of the solution of actually getting this done and getting people into the treatment they need. So when it comes to being advocates, as many as you already know, you have to ask yourself, do you have relationships with people in your state's Medicaid department? If not, we can help out with that. And finally, it's about educating your community, the people around you, policymakers, and working with groups like the Treatment Advocacy Center. We can help you advocate for these things, explain why they matter, and help you get the ball rolling. That is the 12-minute version of the IMD exclusion waiver to Medicaid.
Fantastic, Michael. Thank you very much. If you want to go ahead and stop sharing, I think the next good move would be to introduce the different people on the recording. We've got a nice group with us, and so if you would, please turn on your cameras and wave when I call your name. So first, I'd like to introduce Paul Bohm, who is a history teacher and advocate for the mentally ill. Next on my screen is Mary Hannell, a retired librarian for the city of Santa Clara. We also have Carol Irani, a family and marriage therapist. Thank you for joining us as well. From our membership, we have Tanya Martin, who is a wellness entrepreneur, a lady of leisure, and a Renaissance woman. So she is also the chair of our programs committee. So thank you for being with us. And our team connection is Anita Morgan and Cecilia Babkirk. These are 2 wonderful people who are evacuated, returned Peace Corps volunteers. Both were in Ethiopia until just a few months ago. My name is Rushton Hurley. I'm the charter president of the Rotary E-Club of Silicon Valley, and I am excited for us to be able to start asking questions of Michael about this. And so if anyone has one ready to go ahead and wave. I will pass it over to Paul. So Paul, go ahead and unmute and let's get your question to start us off.
So Michael, thank you for your presentation. It was very accessible, understandable, and interesting. So thank you. I wanted to ask you if you could name 1 or 2 or 3 different individuals that you might mention that we could contact in the Medicaid Department of California.
Currently, Paul, I tell you what I can do. I can send you information for the people at the top of the department, but right now I hesitate to answer that question with specific names, and here's why. Because I've been working for about a month now and have yet to figure out exactly who in California, Medicaid Department, Medi-Cal, there would be responsible for putting pen to paper or hand to keyboard and drafting this waiver, because that person or persons are the ones who make this happen. I've learned the hard way that if you go straight to the top of the Medicaid department or even higher, which is oftentimes someone from the governor's office or the governor, his or herself, their eyes glaze over when you get into something that's nuanced. So I'll tell you what I can do is I continue working on that. And in the meantime, send you contacts for people at the top, just in case any of you know them. If you happen to have connections to those individuals in Sacramento, fantastic. But please give me patience as I continue to try to dig down into California's system there and get the answer to this question, because I don't want to waste your time as advocates.
Thank you.
And one of the things we can do, given that we are recording this in September and that it will be a program for a future week, is that between now and then, we can also get the information that we can add below the recording, so that if you are watching this as a recording the week that it is the program for our meeting, just keep it going down a little farther after you finish watching this, and you'll see information about how to jump in and help.
Right. I'd be shocked if I don't have better answers by the time this goes up. I'm sure I will.
Fair enough. Fair enough. And Cecilia, you have a question.
Well, yes. I'm not sure if this is helpful or not, but when I returned from the Peace Corps unexpectedly, let's see, at that time it was a year and 6 months early from when I expected to come back. I had to try to get back in the healthcare system, and I had 90 days to do that. No, 60 days to do that. It was enormously difficult, and I'm over 65, so I'm eligible for Medicare, and so I could not, of course, just even getting anyone was nearly impossible. You just couldn't reach people on the phone. And so I hope it's better now, and I'm sure it's going to improve with time. But what I learned was that Covered California would not help me, and Medicaid could not help me, because until you are approved for Medicare Part B, you are out of luck. You cannot get any kind of health insurance. And so I finally did reach someone in the local Medicaid office, but I'm not sure that, I don't have their name anymore, but not sure that the local office really can help much. But clearly this is a serious problem that is going to become much more serious. They're all writing about it in the big name newspapers now, about just how serious the mental health crisis is and is going to become because of COVID-19. So it's a real concern.
Right. I'll say that it's not, well, it's indirectly, not directly related to this waiver, but it's a very important thing that you brought up. It's just as important. It's actually a much broader topic, and that is the difficulty of getting yourself or assisting someone else in enrolling in Medicaid, Medicare, really just about any sort of insurance or payer system, but particularly those two. And with this population of folks, with the caregivers, the families of people who have a loved one, an adult with severe mental illness, and they're trying to get them into treatment, that is part and parcel of why I said towards the end of the presentation there that this waiver is one important piece of the problem, and addressing the issues that my colleague Elizabeth discussed a few weeks ago. But the big picture has to do with things like, how do you get someone enrolled? And there are answers to that question, but the answers are different for just about every single state and territory in the union. And they're difficult if this is just someone you're trying to help, you don't have guardianship over them. They're just an adult that needs your help to get enrolled in this very complicated process. That is a major barrier of access to care for this population. And
Yes.
I wish I had an answer for you. What I can tell you is it's a big problem in every state. And it's something that I don't work as much on now, but I have in the past, and it's an uphill battle, and it's something that anytime any policymaker, a legislator, would be they congressional or state level, says, how can we help get people health care? How can we help you and your family? Say, make it easier to enroll in Medicaid. Wouldn't that be nice?
Yeah, well, make it easier to enroll in just about anything like that. I ultimately got my senator to help me out. I would have been without health insurance until a year from this past July, had I not just, freaked out and called her office and said, you've got to help me. Otherwise, I'm here in a pandemic with no insurance. But that is a whole different story. That said, I know people who might know people. And I'm actually happy that I've watched your presentation and asked the questions about this, because I have a good friend who is the chief legal counsel for the water board, but she surely knows just about all the attorneys in every department. And maybe I can find out through her who would be a good person to contact.
I can tell you from my work in other states that when you get to that level of state government, those general counsels do tend to know each other. They have to do their jobs. And so
yes,
that could be very useful. Yes.
Great. Right.
So we will make sure that you two are connected. There's a question in the chat that I'd like to get to. I wonder if there is I wonder if there is a template that other states have used that we in California could make use of for writing the waiver proposal. Certainly when you approach people at the government level, if you have something in hand for them to be able to work from, that enhances your ability to get something done. So please speak to that.
Sure. So there's not a proper and basic template, but what there is, though, are two things. The original guidance letter, which is more than just a letter, but it was kind of the announcement from the Federal Centers for Medicare and Medicaid Services about this waiver. It provided a list of what states must include in their applications for the waiver. And then of the 7 states that have applied, we're just now, I'd like to see more states apply, but we're just now getting to a high enough number of applications that we have, which are publicly, well, one, they're available to the public, but you have to dig for them online. I also have them, I saved them on my hard drive, so I've always got them here. If we have those states to look at them and go, okay, which state is most similar to another state, say California, in a number of demographic or ways related to their Medicaid system. And this is how this state completed a successful application for the waiver. So to the Department of Medicaid in California, you can say, this is the closest thing we have to a template, which is a document of a state who's been successful with this, who's very similar to your state.
So last question before we wind things down, although as longtime watchers of our programs know that we continue to talk to our speakers after we finish the recording. We just try to keep our recording time down to a specific amount. So last question, when this rule related to the 15, 16 beds, right, that limit was put in place, I would assume it was part of some effort to keep from having, kind of some kind of financial black hole related to care of people who might be very expensive. Now, there are things on two sides of that issue related to, well, we need to be caring for people who need a lot of care versus how much money are we going to spend? Is that where the logic was that put the rule in place in the first place, or was it something different?
The answer is twofold. First, very much what you just said. There was a financial reality of figuring up the federal budget for the next cycle when they were passing this legislation, and there was going to be an enormous new expense in the two programs of Medicare and Medicaid. And that's also with the backdrop. I think I very briefly mentioned the mid-60s and the civil rights movement earlier. The backdrop of President Johnson's balancing act between lots of new social programs, which cost money. They helped people that needed help, but they cost a lot of money. And the escalating war in Vietnam, which cost a lot of money. So take everything else out of those two things. Objectively, you must say those two things are expensive. And that was going on. So yes, that was part of the calculation. But the other thing, though, goes back to his predecessor, President Kennedy, and a desire of the Kennedy administration to deinstitutionalize people with severe mental illness, as well as intellectual disability and what we now call substance use disorder, and all those things that tended in those days to end up with people being in asylums that were like worse than a prison in some cases, and they lived there for long term or for life. Trying to put an end to that system and actually get people into treatment. So the idea was that you disincentivize an asylum, a large facility where people are treated like inappropriately, not like patients, but otherwise. Disincentivize that with government money while providing funds and incentivizing more community-based treatment. Great theory, and well-intended, but the problems there are that, one, some people with severe mental illness need more than just community-based services. In fact, the population we work with, we work to help at the Treatment Advocacy Center, is the population of those mental illnesses where therapy and medication are important, but just outpatient services alone are never going to get the job done and get that person stable. And number two, if the government's going to be serious about these outpatient services, they've got to put up the money for that too. And that's never really come to fruition.
I'm looking forward to continuing the conversation in just a moment, but for those of you who've been watching, there are two things we always ask that you do. First, let us know you were here. There is an attendance form just a little bit down the page, and it's just good for us to be able to say, hey, thanks. If you fill that out properly, by the way, it'll generate an automatic email that you can pass along to your club secretary just in case you're trying to make up a miss while trying to keep 100% attendance, which is a righteous thing to do. A little farther down the page, you'll see our forum, our discuss section. And that's where you can leave impressions of both this program and any other content that you see across the meeting. We hope you will engage in that discussion. We love sharing ideas. We try to do so as tactfully and appropriately as possible, although, you know, it's one of those things where important topics need to be discussed. And so we work to try to find ways to do that. So as we always like to do, we hand it back to our speaker for a final word. So Michael, if you would, go ahead and finish us off.
Sure. I want to thank you all so much for allowing me to speak to you today. Thank you on behalf of not just myself, but of course the Treatment Advocacy Center. And remember, if you don't remember anything else in this talk, that there are not enough inpatient psychiatric beds in this country for people who need them. 1115 IMD Exclusion Waiver is one way to get at that problem, but it's a big problem, and it's why we have so many problems we do related to untreated mental illness in this country.
Excellent. Everyone, we will see you next week.